Okay, good afternoon. Thank you very much for inviting me to share some of my thoughts about AI in ultrasound. Sorry, I have a bad throat. But what is first important is I want to have a disclaimer that I know only two equations. One equation is 2VF is equal to cos theta by C. That is my Doppler equation, which I use it always. Second equation, my equation with my patients, how I deliver my care. So beyond that, any mathematical questions, please. I cannot answer. But I'm going to take you through what is potential, where is the potential for us in ultrasound to apply machine learning and make our life much easier. Over the years, I have been working with some groups in this field. And I find it extremely exciting that the image which is actually coming on the screen has much more information to tell than what we can perceive. So this is where we will try to go to. Basically, I will take you through ultrasound. What is ultrasound, diagnostic ultrasound, and what is it that we do, and how the image is produced, and where are the pitfalls that are there for us, primarily for us, the limitations which we have. So we know that ultrasound is produced by piezoelectricity, and 2 to 20 megahertz is the frequencies which we use. And we are basically looking at the interaction of sound and tissue. And we believe that when sound interacts with different types of tissues, we are going to get different types of images. But the important thing is the display. We have several modes of display, which we call as A mode, B mode, M mode, and Doppler mode. In that, of course, we don't use A mode. Only ophthalmologists use A mode. Others do not use it. We use B mode. And the M mode is primarily used for cardiac imaging. And the Doppler is used for identifying blood flow. So now, what is important for us is to understand the acoustic impedance of different tissues and what happens when sound meets a tissue of one acoustic impedance to a tissue of different acoustic impedance. That is exactly where reflections take place. And the amount of reflection that take place depends on the difference in the acoustic impedance between the two tissues. So the resultant image will have several degrees of brightness. If it is completely dark, there is no reflection at all. And if it is bright, if it is extremely bright like this, means total reflection has taken place. So between 0 and 100 is between black and white. We have a number of gray scales where, depending on the degree of reflection, I'm going to get images. So this is how and when I see, for example, liver-air interface, I have 99.9% reflection. Similarly, soft tissue bone interface, you're going to have very high reflections. So these, by understanding these characteristics, I'm able to understand what kind of image is being produced. So I have anatomical knowledge on one side. I know where I'm placing my probe. When I see these images, I try to give some meaning to these images. But the operator decides on how to move the probe and obtain sections. This is in direct contrast to CT and MRI, which are cross-sectional imaging, where the patient goes through the gantry and comes out. You have a series of slices. You can decide how many slices you want, and then they are collated together. You can make it to a 3D, you can do whatever you want. So here, because it is completely operator dependent, the probe movement the probe movement also depends on what I want to see. Supposing I'm looking at static organs, they're not going to move. Liver is going to be here, kidney is going to be here, so I can know exactly where to put the probe. But when I'm doing a pregnant woman, scanning a pregnant woman, and there's a baby inside, the baby is moving around all the time inside. And when I move my probe, I have to make some movements of my probe to ensure I get the particular anatomy of the fetus I want. This is a very big limitation because sometimes the fetus is not in position. I may not be able to get the required images. But for me, there's a compulsion to produce images, not only image the fetus in a particular fashion, in a very, very standardized way for me to get some meaningful information out of it. So most diagnoses are done in real time and the images are documented. If you see the workflow in an ultrasound system, the patient will be on the table, we finish the scan, and the first question the patient will ask is, doctor, is everything all right? Then I have to give her an answer, everything seems to be all right. That means I've already made a decision that everything is all right. So the report is only a documentation which I'm going to give. And this poses a big challenge because as I'm making, sometimes I may not be able to make a diagnosis in real time. I would need further information. I need to have a discussion, and there comes a limitation. But however, majority of the times we are able to come to a conclusion. Now, the ultrasound images are real-time beam mode. They are pre-processed images. So my ultrasound beam which goes inside already is manipulated. There is a focusing involved. There are the method of removing the side lobes are involved. So several pre-processing methods, the power of the ultrasound which goes in, and there is also some post-processing. The returning echoes, the amplitude, the gain, all these things are changed in such a way. There's also some noise and speckle reduction, and there's tissue harmonic imaging. And finally, what you see on the screen is a completely processed image. And when we do AI on these images, these are all already processed images. And I'll also tell you that the display which comes on the screen, majority of the monitors are giving me 256 shades of gray. But actually, the human eye can perceive up to 1,000 shades. So in the recent equipment, they have upgraded their monitors so that I'll get at least 1,024 shades of gray. So that means the quality of the images has changed a lot. Next, most important to understand, about 1/3 to 2/3 of any ultrasound image you take has got artifacts. And these artifacts have to be recognized. Many of them you may not recognize itself, but when you carefully look at it, you will find these artifacts. And during interpretation, it's important these artifacts are removed and the interpretation done from the main image. So this was the ultrasound image many years ago, which was only almost like black and white. Today we have the amount of the gray scaling actually helps us to identify finer details in the image. And I'm able to say if this is the uterine myometrium, this is the endometrium which is there, and this is a small little fibroid which is just pressing on the endometrium. The fibroid has got a small capsule which is what we call as anechoic or without any a black area there. So this similarly, this is I can immediately tell this is a cyst because you can see the bright area behind, which is called as acoustic enhancement. So I'm able to, even though there are lots of echoes which are inside, I say this is a complex cyst which is seen in the ovary. I know where I'm placing the probe. I'm looking at the ovary and there is a lesion like this. So I put 2 and 2 together and come to a conclusion of what it's all about. Now, let's look at Doppler. Doppler is a very important development in the field of ultrasound. And essentially, it's a simple concept of received frequency minus transmitted frequency is the Doppler shift. And the Doppler shift is converted into audio signals. Converted into audio signals. The audio signals are unique to each vessel. So to the extent that if you are familiar with Doppler, when somebody is doing a Doppler in the next room, I can actually say which vessel he is sampling. That is the level to which audio signals are important. But second of course, is low velocity waveforms. Low velocity waveforms are also called as spectral waveforms. These spectral waveforms are the ones which gives us the real quantitative information. And when I measure the waveforms like the systolic velocity, the diastolic velocity, and the mean velocity, it gives me several information. It tells me about the cardiac pump. It also tells about the peripheral, the distal vascular bed impedance, which is there in the vessel. The next thing that happens is, that next change that happened is the color Doppler. Color Doppler changed the way we are able to do Doppler, because pulse Doppler came prior to color Doppler. But today when we actually do Doppler, first we do the color Doppler, then we add the pulsed wave. Why? Because this is called as a region of interest. In this region of interest, a number of Doppler sample points are taken, and whenever there is a movement, there's a flow, the flow is coded as red and blue. If it is a positive Doppler shift, it will be coded as red. If it's a negative Doppler shift, it will be coded as blue. So I'm able to get flow direction. I'm also able to get whether the flow is smooth or turbulent, whether you can see here, this bright spot here tells me that's very high velocity flow there. So instantly I'm able to recognize these are the spot I need to sample, put on your sample volume and get the information there. Then of course we have an issue that once you switch on the Doppler and I don't see any color, can I declare that there is no blood flow in this vessel? Is that the truth? Then people realize that the Doppler has a limitation of when the flow slows down, Doppler is not able to pick it up, simply because the adjustment was not done. Simply the PRF was not low enough to pick it up. So they changed to a new technology, which is called as power Doppler or directional power Doppler. So in power Doppler, it takes away the angle of insonation and just looks at if one cell moves from a point to a different point, the energy that's released from that cell is converted into Doppler information. So today we have technology where we can get absolute very, very low velocities also. Now, as I said earlier, it's important to understand Doppler signatures are different for different vessels. And because of that, we are able to clearly pinpoint not only the flow, disturbances in flow, but also I can get information. For example, this is that Doppler called the ductus venosus Doppler. So why am I saying all this? Because these are the images. For example, here, this is an image which I've got across the tricuspid valve. And this tricuspid valve shows you all the pressure changes inside the atrium. Now, there is an opportunity here for us to completely automate this measurement. At present, it's also available, but in real time, not only to automate, but also interpret it to see what is the kind of pressure that change that's happening. In places where the right atrial pressure is increasing, a warning can come up saying, this baby has got a right atrial pressure increase, so better watch out for something which you need to do. Right. Now, let's go down to obstetrics, and this is just the technology. Now, let's see how we are going to apply this technology. When do we do obstetric scans and why do we do them? In early pregnancy, we do it mainly for confirmation, confirmation of pregnancy, location, and viability. Then the primary scan or the most important scan is the 11 to 14 week scan. At this time, we do dating, number, we do screening for several things like screening for chromosomal abnormalities, screening for structural abnormalities. Over 90% of chromosomal abnormalities can be identified at this stage, and over 70% of structural defect can be identified at this stage. And so this is a very, very important scan where we have the opportunity to go and really understand the images. Then 18 to 20 weeks, again, if we can use for screening, and this scan is also called as a target scan, or the scan which is done generally in all places for identifying abnormalities of the fetus. Then, of course, when you come to the third trimester, we have the growth, how the baby is growing, fetal well-being. Is it well oxygenated? Is it moving well? Is it the fluid around the baby? Is it all right? So how much growth it has achieved, all that can be done. And also time delivery, you combine it with Doppler, It tells you when the timing of the delivery can happen. So the basic principles of image interpretation is we identify the anatomical plane of section and its correlation with the ground truth. Now, who is to decide the ground truth here? So people who learned ultrasound many years ago came and told us, look here, if this image looks like this is what you should say. This is the spine, this is the head. Inside the head, these are the structures. We were trained like that, which means we were given a sense of pattern recognition. But concomitantly, there were also people, what they did, they correlated with actual anatomy. When the fetuses were expelled or there was a termination of pregnancy, they went and did anatomical sections and correlated with the ultrasound section. And they said, okay, now this is what is. And so now we are able to identify clear landmarks, which we consider as the truth. If an expert tells you that this is the choroid plexus, then you can be rest assured that it is indeed the choroid plexus, because that is important for us if you are going to do any image analysis. So the pattern recognition, as I told you, repetitive patterns at various gestation stages. The challenges with moving anatomy. The anatomy of the fetus changes with the pregnancy. In early pregnancy, the appearance is the kidney appearance is completely different as compared to appearance at 30 weeks or 34 weeks. Similarly, the cardiac section, because it's constantly moving with a heart rate of more than about 150 or so, we are going to have an absolute challenge trying to capture the images during systole, during diastole, and also understand what is the thing. But nevertheless, majority of the diagnosis of cardiac anomalies are made on real time. So the International Society got together and said, we have to standardize. And they said, okay, if you're doing a first trimester ultrasound, these are the images you must produce. So when I want to train a system, I have to just take these images and say, come on, these are the images. I give you 1,000 images, 1 million images for the head, for the face, for example, and I get to that. Why is it important? Just take this one image alone. This is a picture of a baby's face at 11 to 14, around 12 to 13 weeks. And from this, I can actually diagnose 7 different abnormalities. Okay, by looking at this, I can say I have excluded 7 different abnormalities. And since this image is, all these landmarks are very, very standard. For example, this little white mark will always come in all fetuses exactly at the same point. And this is your palate. This is your, you can see that little white line is the nasal bone. The other white line is the skin over the nose, and that's the tip of the nose. This is your chin, this is your palate, and this is your midbrain. That's your that's your brainstem, and that's your 4th ventricle, and that's your cisterna magna. So all this, if this line disappears, the baby's spine is abnormal. This is the potential. So if I'm able to train a system and say, understand this image, and whenever the doctor takes, and this information is available on the ultrasound machine, when I do the scan, it automatically recognizes all these landmarks are present. You can tick mark and say normal. So the machine can actually start giving you information. This is a normal image. So that's the potential we are having. Now, also we need steps to improve detection rates. Now, when I want to improve, constantly I want to improve. 20 years ago, the detection rate of anomalies was 20%. Now it is 70%. But I want to move to 90%. How am I going to do that? So what I do is I do the scan by established guidelines. Then I validate the findings. I identify missed anomalies. So I ask myself, every time an anomaly is missed, should I have interpreted this? Can I go back to the image and see whether this image has been appropriate or no? Then I change my protocol. I revalidate the findings, establish a new protocol, and says, okay, I have to turn the probe a little bit this way to get this, so that next time I will not miss it. But this again, method, so retraining, and this is where the potential for automation is there, right? So validation of the finding, just I'm going to show you one example. So this is a fetus where both the lower limbs are fused with each other. Okay, this is called as cyanomelia. And then we've taken a 3D of that showing that. And this is the fetus after birth. We've taken X-ray after that showing the cyridomelia. So we have proved by several methods that this is exactly the diagnosis. And then, so I can now use this image for my training, my system, whichever I want to do. Right. Now, when I looked at how good are we in by our own methods without any automation, we found in our own series where we did 82% had complete correlation with the autopsy. 12% there was an additional information, which means the primary diagnosis was right. So we got the primary diagnosis right in 94% of the cases. So as my human interpretation, I am reasonably good in making the diagnosis. But this is after 40 years of experience. What happens to somebody who starts their career just now, or who's working in a rural area, does not have this kind of exposure, nor has the opportunity to validate their findings and improve their techniques. So some training is given. This is where we need automation to come in, where the knowledge gained from what we do is translated and given to an inexperienced person so that it will be guided along, and that will improve the skills over a period of time. But this is a question which needs to be answered. Is AI going to help to improve somebody's skills, or is it going to make somebody lazier? I say, okay, machine is doing it, so I don't need to interpret. This is also a problem for us, which we are very worried about, right? So the question is, anything that is repetitively done, if it is automated, it saves time, so that we can think of something else. And that's how many of the measurements, the fetal biometric measurements, were automated, and today it is available on the machine, right? So where do we do? There's a potential is that we all know that today retinal images, AI in retina is an established fact. So teleophthalmology it has helped thousands of people and is improving by the day. And I'm going to show you in the ultrasound machine what has actually happened. So this small video which is going to tell you, this is the machine which was
probe thyroid.
He's talking to the machine two things. Okay?
Now I'm just going to start scanning the patient's thyroid.
He's going to say
depth increase. Depth increase.
He's not touching any buttons.
Depth decrease. Depth decrease. Color mode. Color
Immediately
mode.
color comes on. And
freeze.
So the machine is able to listen to all the commands.
Save image.
Both your hands are free. You can freeze the image, store the image.
Unfreeze.
Measure this. It does everything. So this is right. So where do we use AI? Screening, prediction, triaging, diagnosis, of course, drug development. This is all in medicine, treatment, monitoring, and imaging interpretation. Now, in ultrasound, what can you do? You can give probe guidance. The operator can be told how to move the probe. So this was a challenge. In India, for example, you are not allowed to identify the sex of the baby. So the government came and asked us, can you make an ultrasound machine which, when you move the probe, when it comes to the area of the genitals, the image should disappear, so that no doctor will be able to identify sex. This was the government actually called us for a meeting and did it. And from IIT Madras, they said, yes, this is possible. But today what is happening is, if you want to, in remote areas, if you want only limited information, let us make a black box, right? There will be nothing, there will be no machine, there will be no monitor, there will be nothing. You take the probe, the doctor is asked to move the probe with particular sections, 3 longitudinal sections and 3 horizontal sections. The image is all captured. Then it tells you there is a single fetus. The fetus is 20 weeks old, fluid around the baby is all right, the placenta is anterior, and 2 or 3 major anomalies not present. This the machine will tell. And it's in progress, and very soon I'm hoping to see that. So that is probe guidance. It also tells you how to move the probe. Second is how to identify the biometric plane. The biparietal diameter, the occipital frontal diameter, exact measurements to be done. Then anomaly scan completeness. This is something which I'm going to show you. It's very interesting because I know when to start doing a scan. Patient is on the table, I put the jelly, I start. But when am I going to put the probe back and tell the patient, scan is over? When I say I've complete, when a doctor sees a patient, he asks for certain parameters, does some examination. If he's a respiratory specialist, he looks at the chest and say, okay, my job is done. But for an ultrasound, I need to see the complete fetus before I say I have seen everything and declare it as normal. Now, who decides that? It is my sense of satisfaction, okay, I've seen everything, or I have a checklist approach and say, all these things are checked and done. What if the machine is able to prompt me, look here, you have seen all these areas, you have still not seen these areas. Better go and check before you tell the patient, let the patient go. And that is again important because many of the abnormalities which are missed is because the checklist protocol is not followed. And here there is a potential for AI to bring that checklist protocol into the system. Right. So, so let's give some examples here. So we have collected images like this, millions of images over the years. Now this is given to a big database, and then they have done some feature extraction, and now they're able to recognize every part of this image. Not only every part of the image, you can also automatically label the image, measure it. It can give you everything at this point. So I'm going to do the second trimester targeted scan and watch what the machine does, right? What the machine does. So I just started doing the scan. This is a real patient whom we are doing. And here on this side, you're having this big list here. This is the list which is, and if you see this image which is frozen here, I am not freezing them. It is automatically happening as I'm moving the probe. And every time I've done this, one of this will get checked out. So I'm moving the probe now. So I've come to see the abdomen. It has captured the abdomen. It has captured the point where the umbilical cord is entering. All these things are getting checked out now. So now I switch on the color Doppler. It's going to, as long as I don't get the particular frame right, the image will not freeze. The moment I get the particular image, it will automatically freeze. It holds good for even cardiac images, spine images, and the limbs. So now I'm trying to look at the two umbilical arteries. You can see that. There, it is already frozen. And then, so by doing this, what we found was the time taken to do the scan has reduced tremendously. And a junior operator, he cannot make a mistake because if the image is not frozen, he is not taken the correct section. Now, at the end of it, it says after 10 minutes, he says, come on, let me take over. And I find that 6 images have already been taken. I need to take another 7 or 8. I complete that. So this is, it's currently available and operational, which I think is a very, very good improvement. Right. Then, of course, what more? When you do, we have to do the amniotic fluid assessment. So when I see the pocket of amniotic fluid, a number of errors are created in measurement of the amniotic fluid. So this system measures the amniotic fluid always perfectly right. You move all the 4 quadrants, it measures, gives you, and then it does a quick review. So you can see all these are images taken by the machine. And these are blanks. So the blank areas are the ones where we need to fill up with images. So that's the concept. Now, of course, then it comes to the heart, one of the most difficult areas. So what they did was, see, simple to understand that the heart at 24 weeks, for example, is of a certain size and it is located in a particular way. It's always the apex is pointing towards the side, the cardiac axis, symmetry, everything is like that. So once you are able to put it on the machine, have a 3D probe, and then you see the graphic here, you superimpose the graphic on that image and allow it to run, and then just freeze the button. Then it has already captured, it gives you the two orthogonal planes. And then what it does, it tells you this is your start plane. This is the first plane where you see the inflow tracks. Then you see the outflow tracks. Then you see the stomach and the apex are on the same side. Then you see the venous. Then you see the arches. Then your cardiac examination is complete. All with one sweep of the heart. Now, if I have to manually do it, it's going to take a long time trying to maneuver, do this and all that. So this is a very, very good advancement which we have. So what we set out to do is work with a group with this. This is a recent paper which we have published on the computer-aided automated master frame selection technique for fetal echo. So we said, what is it that we can do in our own setting? So you have a cardiac clip. It should identify the diastolic frame automatically. And what it did was able to identify the diastolic frame reasonably well. And this is just as a basic beginning to use it for a full cardiac examination. And again, this was also to do a segmentation algorithm for identifying these chambers. We wanted to automatically measure the chambers, see how well we can identify. So it was observed that MRF results, that is the Markov random field segmentation results in a segmented image close to the ground truth if boundaries of the image are well defined. So the fundamental is your basic image quality has to be good. So if it is there, then it's able to do a reasonably good job. Now comes to the head. Now here I am, we saw about the heart. What about the head? Because the head, there are three standard planes, which we call as the ventricular plane, the thalamic plane, and the transcerebellar plane. And there are 6 most frequently used CNS measurements. And it's possible to do that. So what I'm going to do is to show you another video which we use. So this is this just to show you the console of the machine. So we have acquired a 3D of the head, and I'm going to say Sono CNS. So I'm going to tell the machine, I'm going to look at the head of the baby, and immediately it goes and puts all those images together and says, these are the 3 planes for you. That's your lateral ventricular plane and cerebellar plane. And then I said, oh, go and measure them. So immediately the caliper marks come on those particular spots and do the measurement. But we need to go one step further. So here what we do, once you do the measurement, I also want the images to be labeled appropriately. So those are the measurements which are done and says, come on, label them. So it tells you this is the stena magna, this is the CSP, this is the lateral ventricle. The measurements are also done for me. So for me, it becomes very, very easy. Then a few words about 3D ultrasound. 3D ultrasound has played a tremendous role because before we were doing only 2D ultrasound. Today we capture a volume. And once you have a volume data with you, it allows you to play around. You can slice through the volume, you can rotate the volume, you can do and also make whatever measurements are possible. And more importantly, they have also shown that 3D of the fetal face, there's a potential for phenotype recognition. And they also found that we are able to actually identify the baby has emotions. So you can see this baby crying, you can see this baby yawning, and here you can see this baby smiling. So all these are possible. And what one doctor in Europe has done is he has looked at fetal behavior and correlated with behavior outside when the baby comes outside. So he says there's a potential for identifying cerebral palsy or impaired growth, in intellectual growth after the baby is born. He's done some studies, but still it is not validated around the world. But again, I'm saying there is a potential in this area which can be worked upon. So here we can see the rendering of 3D volume. You can see the spine. Now, when you see the spine, we know there are fixed number of spines. The machine can easily recognize each of those spines, their shape, their size, what they should be, and what the distance should be between these two, and tell you whether this is a normal spine, or this spine has got a little bend, or this spine is abnormal because there could be a skeletal dysplasia which is there. So that is the potential is available. Then in early pregnancy, for example, we can identify literally the Carnegie stages of development by taking this 3D. This will correlate exactly with your embryological picture, which you see in the textbook, anatomical textbooks. So that is the level of resolution that we are able to get on the ultrasound. So here, for example, so this is an 8 weeks where you can see the rhombencephalon, which is a posterior thing. This is the mesencephalon, and that's the diencephalon, which is there. All these are able to identify that. But we can also see through. So here you can see I'm seeing through, I'm forgetting the skull, I'm forgetting the brain, I'm going only to the ventricular system. So here is the third ventricle, and that's the fourth ventricle, and that's the lateral ventricle. So what if the machine is able to give me that this lateral ventricle appears to be all right? Because there are subtle changes in the lateral ventricle which might miss the eye. For example, in infection, in intrauterine infection, there's some changes in the lateral ventricle are the ones which actually gives me the diagnosis. And there's by understanding, confidently calling that this image is normal is what we are actually looking at. And if it flags off saying this image is abnormal, then we can always give information. So what is the clinical value and challenge? Let's see how does it have. I want to take a volume of the brain, for example. Now, when I do by the regular method I'm doing now, it takes about 210 seconds. Okay. With the new technology, with the AI technology, it takes me less than 1 second to get the same volume. And that's the power. That's the power because the system is trained so well that instantly it recognizes the brain volume and gives me intracranial volume in about 1 second or so. Now, let's go beyond the routine, okay? And let's understand fetal adiposity. So this is not something which everybody can do. This is the work with Dr. Saravanan, Uma, and myself have done. She has already told you that in gestational diabetes, the baby has got a possibility of the fat getting deposited earlier. And this may be a marker even before the diabetes comes in the mother comes to light. So this is an exploration in the journey we're doing. But for that, what is the tool we have? We identified that we could measure the fat of the subcutaneous fat. Now, this was a manual measurement that you're doing. So every patient you take measure and you do it. But is there a potential for automation here? Yes, certainly it is. Because what you can do, you can divide the abdomen into so many segments, and you can identify the best segment where you see the abdominal wall, and you can make the system recognize which is the abdominal wall, do the automated measurement and give you, and potentially you could give a batch of 300 images or 1,000 images and or get the measurement done in an instant. So that's the advantage. Then of course we have seen the spine. Let's go to gynecology. Now, recognition of endometrial pathology and recognition of ovarian morphology and pathology. Briefly, we pitched upon this yesterday. So here is a picture, transvaginal picture of the uterus, and that's the endometrial line, and that's the cavity, and that's the myometrium. So here, what I'm looking for is the myometrium homogeneous. Is it smooth? Is the thickness here and here equal? Because if they're unequal, I'm going to make a diagnosis. Similarly, the endometrial lining, is it uniform? Is it irregular? And in a person, what is the volume of the endometrium that comes here? So it's possible now to actually automate it and get the entire volume by the system by itself. And let's see how the endometrial thickness is done automatically. So here is a measurement comes here. As I am doing it, the system is trying to recognize the endometrium. There quickly you can see the caliper marks coming automatically on. So that's an automated measurement of the endometrium. Now, but the challenge is in the ovary. So here is an ovary with lot of little follicles there, and I'm taking a 3D sweep. I want to measure all the follicles. Imagine the amount of time it will take to measure all those follicles. Instead of that, I'm going to tell the machine, please recognize all the follicles, measure them, give me not three-dimensional measurement and also the volume. And this is called as the Sono AVC, or automatic volume calculation. So I go here, I see the AVC follicle, I just press the button there, and in an instant it is going to recognize all this.
Left.
There. It has recognized that, and it is also recognized something which is not the follicle. So these are the images, and you can see the list which comes here with all the measurements which will come there. But what has happened here is it has recognized any cystic area which is there other than the follicle. So this is where some human intervention is required, saying that, well, you have to be, the algorithm is not good enough to exclude things which are coming out of the ovary. So if it still has to be refined. But certainly this has simplified. And coming to ovarian findings, can I tell this ovary as normal? Are there cysts? If it's a cyst, is it a functional cyst? Is it benign? Is it a borderline tumor? Is it a metastatic tumor? So how can we going to do that? So the international group sat together and they said, let us come and fix a certain number of features which are characteristic of malignancy or which is benign. So these are called the malignant features: irregular solid tumor, presence of ascites, papillary projections, irregular multilocular, and then color scoring. Here, these are all benign features. So they said, if any image has at least one malignant feature, then you classify it as malignant. If you have two or more benign features, then you classify it as a benign. This is a very simple classification. These are called as iota simple rules. But that was not enough. They created another model, which is called as the ADNEX model. They said, let's now take the age of the patient, because the risk for ovarian cancer changes with age. Secondly, the type of center who is referring the case. If an expert center is referring the case, they've already done some homework, they're suspecting cancer. That means their diagnosis is more likely to be right than a general practitioner which is doing it. Then serum CA125 is a marker, it's a biomarker for cancer. And of course, 6 ultrasound variables. So when these are the 6 ultrasound variables they put in here, like maximum diameter, proportion of solid tissue, more than 10 cysts, ascites, acoustic shadows, a number of papillary projections. So if in a case you just extract these features and you plug it into a system, what it will do is, so if you put all these, say yes or no, and just do that, and you say calculate, it gives you a report like this. The risk of malignancy is 94.5%, right? And the chance of benign tumor is 5.5%, borderline is 24, stage 1 is 20, stage 2 to 4 is 45%, metastatic is 2.7%. So finally, this turned out to be a clear cell carcinoma of the fetus, of the ovary. So in this case, so the ADNEX model is now being routinely used, but it has a high potential for improvisation, making it better and better and better. And this is one of the very important things which is helping clinicians now to diagnose ovarian cancer in this case. The same has been applied for, to in other areas also. So prediction of, let us say, syndromes. Okay. Now, in a fetus, I diagnose an anomaly. I diagnose different anomalies. Now, all I want to ask is, can all these have a common cause? Let's say if there is a absent nasal bone, if there's tricuspid regurgitation, then there is a increased nuchal translucency, all this point toward Down syndrome. If there's a facial anomaly, if there's a brain anomaly, then maybe it is trisomy 13. So what we can do is, when I do this, by experience, simply by experience, which we call as the Gestalt method, I can identify these and fit them into a syndrome. Like for example, this is trisomy 21 Down syndrome. This is Edwards syndrome or trisomy 18 because it's got a strawberry-shaped skull and a clenched fist. This has got holoprosencephaly and also a cleft palate. I know it's trisomy 13. And this is Turner syndrome because it has got a increased fluid behind the neck. So these are things which are standard which can do. But in other areas, it is not possible. There are different anomalies which may come. So I recourse to some databases which are there. One of them is called Online Mendelian Inheritance in Man, or OMIM. So I diagnose a genetic disorder by identifying the features, putting all of them in, and the OMIM will actually give me the most probable diagnosis. So here I've had plus synophrys and hirsutism, and it gives me a number of abnormalities. So I have to choose between these. Very difficult, isn't it? But here it's most likely Cornelia de Lange syndrome. Or I can go to another database, which is called as the POSUM. And this POSUM, if I add encephalocele, cranial meningocele, then it gives me cerebro-oculorenal syndrome, Joubert syndrome, or Meckel syndrome, which could be there. Then that also has been automated into an AI system now, which we call as the Sonio system. What they have done is all these databases, they have used AI to go and, scrounge the databases. Whenever you put any findings, it goes and looks up at all these databases and comes up with a result, with the most probable result. So this assist in fetal anomalies and associated syndromes, they combine many risk factors with signs visible on the scan, optimize diagnostic performance, and facilitate preparation of multidisciplinary meetings. So what is the performance of this? So this article was recently published, and they have put a clear disclaimer that this is a preprint and not had been peer reviewed. It reports new medical research that has yet to be evaluated, so should not be used to guide general practice. But this has come out as a commercial product, right? And 294 recognizable syndromes, 68 anomalies, and accuracy rate of greater than 95% for the top 7 diagnoses produced. So this is potential again. But because certainly with the current technology AI available, this is a huge potential to that. So finally, what's the future? So we have machine learning and deep learning techniques, learning from experts. So somebody who's got some 20, 30 years of experience in ultrasound, how can that person contribute to the future, not being an engineer, not being somebody who understands machine learning, but he's using a machine. Now, should that machine not learn from him? Is the question, right? So this is my wish list, and this is all for you. The ultrasound equipment should learn from the experts. Every time I do a scan, it should be able to gather information of how I have done the scan and able to gather the information. And this knowledge should be available in a repository, which can be plugged out and plugged into another machine. So the next person who uses the machine should prompt him. This is how the guy did. He also did to do the same way. That's where we want to reach. And it can be deployed in remote areas with lack of skills. So how does the future ultrasound report should look like? Single live fetus at 20 weeks, 2 days, appropriate size for period of gestation, liquor is adequate, placenta is anterior high, visualized portions of the anatomy appear as per described norms, inadequate visualization of the lower limbs and lips, further examination is required. One press of a button, the system should throw out this kind of a report. So the last slide I'm going to give you is what should be the future look like. This is really something which will be interesting. The machine is going to tell you, hello doctor, this ovary looks appropriate in size and has 12 antral follicles. You can go ahead with stimulation. Stimulation, it should be not simulation. She is at high risk for hyperstimulation. It is going to tell you that. And the uterine myometrium appears homogeneous and symmetrical. The endometrium also shows a triple line and corresponds to the 13th day of the cycle. So please go ahead with intrauterine insemination if you want to in this cycle. If the machine is able to tell it, look how life will change. Thank you. Any questions?
Anyone? It's yeah.
Findings and talks. So my question is very, I think, general. So you showed a lot of products also that have come out of these. Are we looking forward to some products from India as well to emerge?
Yeah. So in India, one of the problems I faced is the number of, for example, I'll give you one simple example. It's automated measurement of the nuchal transparency at 11 weeks. This was given as a project to a MPhil student many years ago, and it was successfully done. It came off very well. So what I did was I got very excited. I went and showed it to the whom we call as the father of ultrasound in the world, obstetric ultrasound in the world. He came to India at that time. I went and showed him. The first question he asked me was, "Have you patented it?" I said, "No." Because I was excited about it, I showed you. He said, "Sorry, it's too late for you." 6 months later, it came as a thing on the ultrasound machine, as a technology on the ultrasound machine, and we lost out completely. So the problem here is from making something to protecting the IPR and becoming negotiating with the company to incorporate it, because this can only go into a manufacturer has to pick it up. Now, this is where the necessary kind of guidance, the necessary kind of flow path is lacking here. There are several things that has happened like this in this way, and I think that's where we should work on. Now, people from other countries have come and asked, "Okay, can you work with us in this?" So I worked with them, and in another few months' time, some major things are whatever I've been speaking to you. Most of them are going to come in the machine in the thing which is going to come. So there is now validation is going on for identification of anomalies itself. So anencephaly or abdominal wall defect. So those is going on at a very fast pace. So we need to move very fast, very, very fast if we have to reach there. And I am all the time hoping that some people from India will be the ones who will be dictating, because what we have is a huge wealth of information. The database we have, for example, I have like 20 million images. Who's going to use them? Right? And we have taken care, we have taken all the, I heard the talk on ethics. So regarding these images, we have made sure that every patient who comes to us, we take a detailed consent for the future also, so that we can use them.
Yeah, so those images were really amazing to see. And is there any progress on diagnosing endometriosis? I understand that's one of the most difficult.
Yeah. So endometriosis, there are some people who are very skilled at making the diagnosis, because it's a training that you require to identify that. So it's entirely by training. It has there is no AI-based algorithm for that as yet. Yes. Yes.
Just to add to that, the challenge with endometriosis is everything is not visible on ultrasound unless it becomes a cyst. So there can be just spots in the peritoneum, which, I mean, unless you're like super focused, I think ultrasound as a technology may not be able to pick up some types of endometriosis.
Thank you. Really, really enjoyed it. Actually, I think this is the first time I hear you speak. I think we had several discussions, so thank you. Yeah, it's what you highlighted shows some academic professionalism also, hasn't it? About so we have, as you say, a lot of skills, a lot of pathology, a lot of talent, and how do you actually translate that into international scene is a challenge for us. My question was, do you think AI is the only way for replacing skills in settings where we don't have enough sonologists?
Well, that's a very tough question because you use the word only way. When you say only way, then I'm being very dogmatic about it, and I don't think we can ever be dogmatic about what we say as far as medical care is concerned. So we have to be very careful. I feel that because I've trained a lot of thousands of people and also trained people at the primary health centers, I'm able to understand their level of understanding and how much time their learning actually takes place. Typically in India, when you look at a person working in a primary health center, their tenure in that primary health center is very uncertain. They'll be there for 1 year, or they'll may get transferred to a different location and a new doctor will come into place. So constantly there is a churn of these people and new people keep coming. So in such a scenario, to keep going on training each person is going to take a very, very long time. And so there we can impart some basic skills. But if there is AI, it is going to help us to at least achieve a certain minimum. That say, is there 1 baby or 2 babies? Is there a placenta previa? Is there a major Lycar is less? So does this patient needs to go to the higher center? To that level, if we are able to do, much of this can be got by automation. So that's what I believe.
Hello, thank you, sir. This Ram here.
Yeah.
That's an excellent lecture. It's a shame that I haven't heard you before your lecture. Sir, what do you think, as there are very handful of people in India who are actually very committedly working towards this goal? And what do you think as an ecosystem to catalyze the roadblocks that you have said? How do we catalyze this research forward? How do we get together and move this quick?
Okay. So if you want to take it forward, I feel there should be some departments who are dedicating funds in a very focused manner. I will give you this example of take IIT Madras, with whom I've been working for a long time. 13 years ago, a PhD student, the problem was simple. If I see a lesion in the liver, I want to know whether it's malignant or benign. My challenge at the time as a clinician was hemangioma of the liver also appeared in a particular fashion. A metastasis also appeared in the particular fashion. But there is a small difference between the two in terms of brightness. So how sure am I to do this? So we need to do a biopsy for everybody. If I do a biopsy on a hemangioma, there's a risk of bleeding. How can I avoid it? So this was the problem given. And she came out with a very beautiful paper, a PhD thesis, on which they said you can 97% of the time, you can decide benign or malignant by looking at the backscattered echoes. She did a lot of feature extraction on that. So I literally begged her, take this to the next level. But the person went to a different career, different thing, the whole thing went down the drain. So where is important is we need people who are willing to stay committed in a particular thing. The journey to that point is a very slow and steady point to that point. It doesn't happen overnight. So somebody has to sustain them to that level to keep their interest going, and then only things will work. So there is a disconnect at some point. Great ideas are coming. great ideas are coming, but when it's executed, we are missing out at the last. I think that's the way we have to change the ecosystem to that.
Yeah, I think it's kind of understandable that PhD students will leave and go somewhere else, but the environment, her lab, her advisor, all that should still be in a position to push it. The institution should be able to support
Exactly.
it. So we have to move. And I think IT Madras is actually taking a lot of steps towards
Yes.
this kind of thing.
I think that
And,
one-
Hemant is there
That's
maybe.
one.
Anyway, I think, Shinjini, we'll take one last comment from Shinjini and then we'll break for lunch. Thanks. In people actually.
For the online.
So this is a question that we've debated very often in our own group. Should it be the academia or the industry to take it forward? We don't have an answer and we are struggling with that with our
Correct.
products. So
Correct. Very true. Very true. Academia or industry. So this is the academia takes it to a particular point and expects the industry to pick it up. So our own product, which is patented, called ArtSense, which also got the IEEE award, where you just, it's like a pen now. You place it on your carotid in 15 seconds, it tells you the elasticity of the carotid wall. Nearly 6,000 patients have been done in that, validated against the gold standard, everything has been done. And the last 2 years, they've been waiting for the industry to come and pick it up. So what does the academia do? The product is ready. It's been proved. And so the next thing what the academic can do is add more studies. So now they're starting to know a study on preeclampsia or whatever it is, they're exploring the possibility of that and getting the funding. So, but how long can it go on? Because once the amount of effort that went into making that from a big box like this to a pen, miniaturizing the whole thing, was a journey. I was there literally along with it throughout the thing. I understand how much effort has been put in. Who is going to compensate for that effort? And somewhere we need to find this answer to do that. So I feel the industry not wanting to engage meaningfully in India, and the international industry is multinationals are engaging in other areas, because I know of centers where they are doing some research and all the time I can see the industry people sitting there and getting things done. Then why are they not coming and supporting us in the way that needs to be supported? This is a question I think we need to sit across the table and try to sort it out.
Okay, so let's thank Dr. Suresh again, and we'll break for lunch and